effect on the veins. And once there's that tonic effect there, blood is finding it difficult to return to the heart. So you realize that you may start feeling that tingling sensation in the lower extremities because you are not having blood returning to the heart. You may have blood pooling at the legs and all that. So typically, that is how the patient may describe the pain in peripheral venous disease. Any questions? Okay. So now we are done with the vein. We have done with the E. The next one is S. So the S stands for skin. So the first S stands for skin. And the skin, we are looking at the skin temperature. We are looking at the appearance of the skin, the hair, and the nails. So for peripheral artery disease, what do you expect the temperature of the legs to be? Do you expect it to be cold? Do you expect to be warm to touch? What do you expect in peripheral artery disease for the skin temperature?
It will be cold.
Yeah, it will be cold. So if you are not having blood to the extremities, the temperature at the extremities will typically be cold. And this is usually seen in patients with the vasospastic peripheral artery disease. When there is vasoconstriction, you have reduced perfusion, and that can cause cold extremities. So that is one of the clinical presentation in terms of the skin. Aside the temperature being cold, what can also happen is because you are not having enough blood getting to the extremities, the skin there becomes very dry. It becomes very dry and scaly. You know, the blood doesn't just contain oxygen, it contains nutrients and other substances that help the tissues. So if blood is not getting to the extremities, the skin becomes very dry and scaly. And in terms of the nails become very thin and brittle. So you have very thin and brittle nails, and the hair on the affected limb may fall off. So you can have hair loss. So you can have hair loss on the affected limb. So if the peripheral artery disease has affected your right leg, you may realize that your right leg getting to that part may be hairless compared to the left leg. So these are the typical presentations for the skin in peripheral artery disease. For peripheral venous disease, the issue is not because blood is not getting to the extremities, but rather blood is pooling at the extremities. So in terms of the temperature is warm to touch. So that place is warm to touch. And in terms of the skin becomes very thick and tough. So the skin becomes very thick and tough because it has to accommodate all the blood pooling at that extremity. So over time, the skin there becomes very thick and very tough. Then in terms of the coloration, there may be brownish discoloration of the affected limb. So when you have blood pooling there for a long time, you may have tissue damage and all that. That will reflect as changes in the skin color at the affected limb. So you may have brownish discoloration at the affected limb. Any questions? So if there are no questions, we will move to the next S. So we've talked about various positions, we've talked about elevation, explanation of the pain. We've talked about the skin, what you expect to see on the skin. The next thing is the strength of pulse. The strength of pulse. So for peripheral artery disease, typically when you check the lower extremity to see if you can find any pulse, what happens is, because you have reduced perfusion, you may not feel any pulse at all. Or if you are feeling it, the pulse will be very weak. So you have either weak pulse or absent pulse at the lower extremities for peripheral artery disease. So strength of pulse absent or very low. Then for peripheral venous disease, the issue is not about blood getting to the extremity, but rather blood pooling. So you can easily find the pulse. So pulse is typically normal. So the pulse typically normal and present in peripheral venous disease, but for peripheral artery disease, it may be absent or it may be a very low pulse. You get a very low pulse, or it may be absent. All right. Any questions, or we move on?
So,
Yeah.
so with regards to the strength of the pulse, how do we go about it? Like, how do we check the pulse with regards to that?
Yeah. So there are lots of places to check pulse. So the common ones we know at the hospital is when they are checking pulse around the brachial or the radial artery. These are the common places that they may check pulse in the hospital, or even the carotid artery. But there are other places you can check pulse at the femoral, just around the inguinal region. You can also check pulse around the feet. So usually we call it the dorsalis pedis. So the dorsalis pedis is there's a pulse area you can check around the foot, and it's just around the ankle region. So you can check pulse around the ankle region. Then around the knee, just behind the knee, you can also check the pulse around the popliteal artery there. So there are lots of places to check for pulse. But because we are dealing with peripheral artery disease, which affects the lower limbs, if you go and check carotid, you are doing cos 90. But it's rather you check around the lower extremities of the leg. So around the ankle, around the ankle is typically where you check the pedal pulse. And that can tell you whether it's weak, it's absent, or it's normal. Any other question?
Sir, please, is there a
Okay.
situation where a patient can have both PAD and PVD?
Yeah, so I mentioned it when we were talking about the causes. I mentioned Buerger's disease or thromboangiitis obliterans, which can affect both the arteries and the veins. So you can actually have both peripheral artery disease and peripheral venous disease in Buerger's disease.
But aside that, in a normal person who is not a smoker, can the person still experience it?
Yeah, so if you have the risk factors for both, you can actually develop both. So if you have diabetes, you are also pregnant, you are also in terms of your age, you have also advanced in your age, you can develop both artery, peripheral artery, and peripheral venous disease.
Okay, thank you.
Okay. Any other question? All right. So aside the vein explanation of the pain, the skin, the strength of pulse, the next thing is E, and the E stands for edema. So edema. So which of them do you expect the patient to present with edema? Peripheral artery disease or peripheral venous disease?
Peripheral venous disease.
Yeah, so edema is usually absent in peripheral artery disease and is usually present in peripheral venous disease. So that's one thing you can look out for. So if someone walks in, tells you they are feeling pain in their legs and all that, you want to know whether there's edema. Because if there is edema, then you are most likely dealing with peripheral venous disease. But if it's not edema, then it's likely to be peripheral artery disease. Okay. The next thing is L, which is lesions. So lesions. So typically, we look at the lesion in peripheral artery disease. What happens is, because there's reduced perfusion of blood to the lower extremities, the lesions that are formed are usually at the peripheral, so at the extremities, so around the toe, around the top of the feet, around the lateral ankle area. So these are the typical areas you find lesions for peripheral artery disease. So you can find it around the toes, around the top of the feet, then around the lateral side of the ankle. So these are areas you typically will find the lesion. And in terms of the characteristics of the skin ulcers or lesion, what happens is, for peripheral artery disease, you have very little drainage. So in terms of fluid or drainage that is coming from the artery, you have reduced drainage because there's reduced perfusion to that part. Aside that, in terms of the circumference, typically the circumference will be round for peripheral artery disease. So when you look at the ulcer, it's usually round. So that's the typical findings you find in peripheral artery disease. Then when you look at peripheral venous disease, typically these ulcers or venous ulcers tend to occur at the medial part of the lower legs. So instead of around the foot where you may have lesions, you are likely to have lesions around the medial part of the leg. So that is around the shin area. So where your shin is, that is where you are most likely to have the ulcers. And in terms of drainage, because there's a lot of blood pooling around that side, you have a lot of drainage from the ulcer. So you may have a lot of drainage from the ulcer. And in terms of the characteristics of the ulcer, it's usually irregular and the depth is usually shallow. When you look at the ulcer, the appearance is irregular and usually shallow in depth. But for peripheral artery disease, it's usually the depth is deep and is usually non-discharging, or there's no discharge coming from the wound, and it's typically at the extremities or the top of the feet. But for venous, usually around the medial part of the leg, so around the shin area, and it's usually very discharging because you have blood pooling around that site. We are also saying that for hello, can you hear me?
Please, I don't really, I think I don't, yeah, I can hear you, but I don't
Okay.
understand the lesion part. Please take it again.
So the lesion is an ulcer that will form because you are having peripheral artery disease where there's reduced perfusion over time. What happens is you are not getting oxygen there, you are not getting nutrients there. So that place become conducive for ulcers to form. You may have infection, anaerobic organisms can grow over there. Typically, for arterial ulcer or in peripheral artery disease, that ulcer will form at the extremities because it's an ulcer that is formed because of reduced perfusion. So it's typically formed at the extremities. So around the toe, around the top of the feet. And we are saying this ulcer is usually deep. So in terms of the depth, it's usually deep. So the term we use for that is punched out because the depth is deep. And in terms of fluid discharging from this ulcer, it's typically non-discharging because the issue is reduction of blood to that part. So if you are having reduced blood, in terms of discharge, you have very little to no discharge from such a wound. If you compare that to peripheral venous disease, the issue is blood is pooling at the lower extremities in peripheral venous disease. So typically the venous ulcers that are formed are not at the extremities, but rather around the shin. So we call it the medial part of the leg. So that is around the shin area. And typically, this wound, we are saying it will be shallow. So in terms of the depth, it's shallow, it's not deep like the peripheral artery disease. And in terms of discharge, because the issue is not with blood perfusion, there is a lot of blood pooling there. So you tend to have a wound that has a lot of discharge coming out from it. So it's usually highly discharging. And we are also saying that we can also find this typically around the medial part. And the appearance itself, it will be reddish because you have a lot of blood pooling there. So in terms of the appearance of the wound, it will also be reddish. Is it clear?
Yes, please, it's clear.
The reddish, is it for the venous, peripheral venous?
Yeah, the venous. The artery, the wound will be pale. For peripheral artery disease, the wound will be pale because you have reduced perfusion. But with peripheral venous, the wound will be reddish because you have blood pooling there. So all these are ways that you can differentiate between peripheral artery disease and peripheral venous disease. So you can differentiate it based on the various positions that help relieve the pain, the explanation of the pain. So if they start telling you, oh, for some time now, if they walk for a short distance, they start feeling pain within their legs. That is intermittent claudication. That should tell you it's peripheral artery disease. But if they start telling you, oh, for me, for the type of work I do, I walk around, I stand a lot and all that, at the end of the day, I realize that my legs are swollen. And typically, when I keep my legs on pillows above my heart level, I realize the pain is relieved. So all these are things that sort of point to peripheral venous, because that one, we said the pain will be relieved when you elevate the legs. And usually, in terms of the edema that will occur during the end of the day when they exerted, they stood for a long time and all that. So that is typically present in peripheral venous disease. They may also tell you their pain is very sharp. So if the explanation of pain is very sharp, then it's peripheral artery. Right? They tell you they feel their legs are heavy. The pain is not really severe, some dull pain, then it's likely to be peripheral venous disease. If they are telling you they have ulcers on the leg and you examine the ulcers are at the extremities of the leg, typically will be peripheral artery. But if it's around the shin area, then you are looking at peripheral venous. So all these are ways you can differentiate between peripheral artery disease and peripheral venous disease. Is that clear?
Yes, please.
Okay. So let's move on to talk about the diagnosis. So diagnosis. So for diagnosis, usually the first thing you should know when it comes to diagnosis is history. So you should always take history in diagnosis, because the history can even help you with a diagnosis before doing any other lab. So some conditions, the history alone is enough to diagnose the condition. If you do any labs at all, the labs may be there just to further confirm your diagnosis. But you can actually diagnose the condition from so you can actually diagnose the condition from the history. So what are some of the things you want to ask the patient if you want to diagnose peripheral artery disease or peripheral venous disease?
To describe how the pain is like.
So basically all the things we just talked about, the vessels, you want to first find out for how long has it been happening, which part of the leg are they feeling the pain. If they start telling you, oh, I started feeling it about 2-3 months ago, and where are you feeling the pain? It's just the right leg. And I've realized that when I walk for a short distance, I start feeling pain in my legs. The moment I rest, the pain is relieved. That is a sign of intermittent claudication. If they tell you that when they sleep, they realize that when they sleep and they are having pain within their legs, the moment they elevate the legs, the pain reduces. But the moment they dangle the legs, the pain worsens. Then that's more of peripheral venous disease, because you are saying the pain will reduce when they elevate. The pain worsens when they dangle the legs. If they start telling you they feel their legs, right leg maybe is colder than expected, and they realize some hair loss on that part, and the nails there are very brittle, almost every time they are breaking off and all that, that could be a sign of peripheral artery disease. So all these are things you want to find out from the history. Do you want to find out, do they have any ulcer on the leg? Which part of the leg is it? Is it the medial part? Is it the extremity part? That could tell you the type of pain, the type of peripheral artery disease or peripheral venous disease. Then you could also find out whether there is edema. Is there any swelling in the legs or not? If there's swelling, then likely to be peripheral venous. If there's no swelling, likely to be peripheral artery disease. So all these things are needed in the history. Aside history, you also want to clinically examine the patient. So you want to look at the legs. So you want to clinically examine. And this is where you want to examine whether there's pulse or there's no pulse. So you check around the ankle to feel whether there's pulse. If there's no or very weak pulse, then you are likely dealing with peripheral artery. If the pulse is normal, then you are likely dealing with peripheral venous. You also want to check whether there's an ulcer. So you want to examine the ulcer, whether it's exudating or non-exudating. If you have ulcers that are exudating, you have a lot of discharge coming from it, then you are likely dealing with peripheral venous. But if the ulcer is non-discharging, likely to be peripheral artery disease. So all these are things you want to check for in your clinical examination. So after history and clinical examination, there's another test you can do. And this test is usually a bedside test. We call it the ankle brachial index. So the ankle brachial index. So that is one of the bedside tests you can do in patients you are suspecting have peripheral artery disease or peripheral venous disease. So usually we use that in peripheral artery disease. When you want to diagnose peripheral artery disease, you can do the ankle brachial index. So from the name, what do you think we are looking at? Ankle brachial index. What do you think we'll be checking for? Any ideas?
The blood pressure.
Yeah. So basically, what you'll be checking for is the blood pressure. So when you're checking for blood pressure, we are saying we are doing ankle brachial index. So you want to check the blood pressure of the ankle over the blood pressure of the brachial. The brachial is the arm. That is where we usually check our BP. So the other place you'll be checking is the ankle. So it's an ankle brachial index. And this, you take the blood pressure of the ankle over the blood pressure of the arm. So usually blood pressure, you take two readings, right? So you get a systolic value and you get a diastolic value. So for ankle brachial index, we are interested in the systolic because that gives a reflection of how the heart is contracting. So we look at the systolic values only. So the systolic blood pressure of the ankle over the systolic blood pressure of the arm. So what we expect is if the patient has a normal ankle brachial index, we expect the range to be between 0.9 to 1.1. So if the patient has a normal ankle brachial index, that is where we expect the value to be. But the moment the patient ankle brachial index is less than 0.9, that means the patient has peripheral artery disease. If we do the ankle brachial index and the value is less than 0.9, the patient has peripheral artery disease. Any questions?
So how about if it is greater than 1.1?
So if it's greater than 1.1, then the patient has a non-compressible calcified vessels. So if it's greater than 1.1, so if you have a non-calcified and non-compressible calcified, brachial index is just showing a reflection of the systolic blood pressure. So if the heart pumps, we expect that the pressure.
Sir, please. Yes, sir. Please. Everything you were saying before this time, the line kept breaking and going on and off. I don't know if I'm the only one. So if you can please take it again. Why you were saying the greater than 1.1 or greater than 1.2, like 1.2 and above, that part.
Hello.
Hello.
Can you hear me?
Yeah, we can hear you.
Okay. So I was talking about the ankle brachial index. So basically, we are taking the blood pressure of the patient's ankle and also the blood pressure of the arm at the same time. And what we want to check for is that if the heart should pump blood, we expect that the systolic pressure within the vessels around the arm should be almost equal or close to the systolic pressure within the lower limbs. But if you have peripheral artery disease where there's an occlusion or there's vasoconstriction within the vessels, what it will mean is that the pressure within the lower extremities will reduce compared to the upper extremities. So when you do the ankle brachial index, we take the systolic blood pressure of the ankle over the systolic blood pressure of the arm. So if you get a value between 0.9 to 1.2, 0.9 to 1.1 is said to be normal. So that's a normal ankle brachial index. If it's less than 0.9, then you are dealing with someone with peripheral artery disease, because the pressure, when you realize, when you do the calculation, you realize that the ratio will be less than 0.9. If it's 1.2 and above, then you are dealing with a non-compressible calcified vessel. So I was trying to explain this. So we can use an example. So maybe you did blood pressure of the arm and you got, say, 140/90. And you check blood pressure of the lower limbs and you got, say, 160. So let's do the calculation. So the arm was 140/90. The lower limbs was 160. We are using the systolic blood pressure of the ankle over systolic blood pressure of the arm. What are we getting? So if you do the calculation, what are you getting? Has anyone done the calculation?
So you
So
get
I
a
get
value of 0.714.
You are getting a value of what?
0.714.
0.714. So 0.714 means the patient has peripheral artery disease, because when you look at any ankle brachial index less than 0.9, it means you have peripheral artery disease. So when you looked at the upper arm, you realized the patient's systolic was 140, and the systolic for the ankle was around 100. So you can see a 40 millimeter mercury difference. So that should tell you the pressure that is getting to the lower extremities is reduced. And this is because there's either an occlusion or there's vasospasm. So you are not getting that same pressure of blood getting to the extremities, for which reason ankle brachial index is less than 0.9. And the other extremity is, the other side of the coin is, when you do ankle brachial index and it's greater than 1.2, so 1.2 and above, that is a sign of a non-compressible calcified vessel. So what it means is that if the vessels, ideally the vessels are elastic, they are supposed to constrict and expand to accommodate the pressure. So when the vessels become calcified, such that they are hard and they are not able to expand and constrict as expected, you realize that the pressure in the lower limbs becomes greater than the extremity, because now the vessels are so calcified that they are wide open and they can't constrict when there's pressure difference, and they are always calcified and widely open. They are hard. So that is a sign of a non-compressible calcified vessel when you get ankle brachial index above 1.2 and above. So these are the things you can do at the bedside to actually diagnose peripheral artery disease. Any questions? Okay. So aside the ankle brachial index, you can also do the Doppler. So you can do Doppler of the lower limbs. And basically, the purpose of Doppler ultrasound is supposed to visualize the vessels to see if there's any occlusion or there's any obstruction or there's any damage to the vessels. So that is when you can do Doppler. So that is a way of actually confirming the diagnosis. But typically, we usually wouldn't get to Doppler unless maybe you are suspecting some DVT, you are suspecting some other conditions. But based on the ankle brachial index, you can easily diagnose peripheral artery disease. And also the history can also help you diagnose peripheral artery disease. Any questions?
Doc, please can you check that again?
I'm saying the diagnosis is usually clinical. You can use the history and clinical examination to diagnose peripheral artery disease. Usually what we use to sort of confirm after doing this clinical examination is to do the ankle brachial index. So that is what we can use to confirm peripheral artery disease. But if we are suspecting that maybe for peripheral artery disease or peripheral venous disease, so for example, peripheral venous disease like this, if you are suspecting the patient had DVT or SVT, for which reason the patient developed peripheral venous disease, you can use the Doppler ultrasound to confirm your DVT. Other than that, for peripheral artery disease, ABI and the history is what you use to confirm your diagnosis. For peripheral venous disease too, you can use the history, clinical examination, and you can also use the ultrasound. We don't use the ankle brachial index, in peripheral venous disease. It's only used for peripheral artery disease. But you can use the ultrasound to rule out your DVT, any structural abnormalities and all that. And you can also do angiography. So angiography is a higher technique where you want to actually visualize the vessels, and they can tell you whether there's any occlusion, there's any valve injury, or there's any distended valves or damage to the walls. And this requires a contrast. So that becomes a little invasive. So because of that, it's usually reserved for interventional purposes. So if you want to intervene, maybe you've seen that there's a clot in there and you want to intervene with, say, maybe thrombolysis, or you want to remove the clot. That is when you do the angiography. But usually the ultrasound, the history, the clinical examination is enough to diagnose. Any other questions? All right, so the next thing we'll be talking about is management. But for the management, we'll talk about it hopefully next week. So we'll talk about the pharmacological management for peripheral artery disease and peripheral venous. Once we are done with management, we'll do some questions on peripheral artery disease and peripheral venous disease. So that's how I teach. After every topic, you have questions on the topic before we move to the next topic. So we'll do the management hopefully next week, and we'll do questions on the topic too as well. Any questions before we end? All right, so if there are no questions, hopefully next week. Yeah.
When you were talking about the lesions, you said they look irregular. How
Yeah.
does that look like? Is that
So we are
different?
talking about the edges of the lesion. So if
Oh,
you have ulcer and the edges are round is regular. So for peripheral artery disease, the edges are typically round. So that's a regular shape. But for peripheral venous, you have irregular edges. So it's in terms of the edges.
okay. Thank you.
Okay. Any other?
Yes, please. Please, are there instances where the ankle brachial index cannot be done in a patient?
Yeah, so if the patient is amputated, you can't do ankle brachial index. And if the patient is amputated, then what you can do in such patient, because for such patients, so if you want to take ankle brachial index and maybe they have, say, below the knee amputation. So below the knee amputation, they may not have a foot, but they have a thigh, they have a knee, they may have a shin. So you may not have any place to check for your ankle pressure. Just that such patients, you may still have peripheral artery disease, and you may have to diagnose with the ultrasound, the Doppler ultrasound. Are you okay?
Yes, please. Thank you.
Okay. Any other? All right. So if there are no other questions, hopefully next week we'll meet again. Have a good evening.
You too,
You
sir.
too. Thank you
Thank
so
Thank
much.
you, Claire.
Bye-bye.
Thank you.